Welcome to Let's Talk Micro. Hello, everyone. Welcome to another episode of Let's Talk Micro. As always, I hope you had a great week. And you can always find Let's Talk Micro on Apple Podcasts, Spotify, Google Podcasts, Amazon Music, Stitcher, Pandora, TuneIn Radio. Wherever you listen to podcasts, you can find Let's Talk Micro. As far as social media, I am on Instagram as Let's Talk Micro, no apostrophe, on Twitter as Let's Talk Micro 1, on LinkedIn as Luis Plaza, a YouTube channel, Let's Talk Micro, and on TikTok as Let's Talk Micro. So please go ahead and subscribe to the podcast, download episodes, leave any feedback, leave a review if the app allows you to do so, leave any feedback on social media, any possible podcast topic suggestions. You can also email those at letstalkmicro@outlook.com. As always, any feedback, any suggestions, they are always welcome and appreciated. And if you haven't checked out the previous episode, please go ahead and do so. It was a great episode about Candida auris. I mean, you have seen on social media, the CDC in March, they released a warning about, the high levels seen in healthcare. So definitely, I had the chance to talk to Dr. Sean Lockhart, which is a senior mycologist at the Centers for Disease Control and Prevention. It was a great episode. So he came in, he talked about Candida auris, what kind of population it's seen on, as far as, resistance, what kind of resistance Candida auris shows. And something interesting that they went back, well, he says, that resistance, the organism is rapidly acquiring resistance. And they went back to a whole bunch of isolates that they hadn't frozen. And then they tested them, and most of them were actually susceptible to the same drugs that the organism is now showing as being resistant to. So definitely overall, it was a great episode. So please, if you haven't checked it out, go ahead and do so. So on today's episode, we have two recurring guests, which are doctors Andrea Prinzi and Rodney Rohde. They've been on the podcast before. They have done, more than one episode and about different topics in microbiology. As you know, definitely Andrea Prinzi, she came in, she talked about respiratory cultures. She did a great episode on breakpoints. Dr. Rohde, he talked about monkeypox. He talked about rabies. So overall, some great episodes where I had the pleasure of having them as guests in the podcast. So on today's episode, they come in to talk about an article regarding biofilms and antimicrobial resistance. So it was a great article, and I will post it on the show notes. But they definitely, they talk about biofilms, what are biofilms, where are they seen, what's the role of biofilms in AMR. And I like how Andrea Prinzi, she makes the distinction about that the AMR seen with biofilms is not necessarily, it's not the same AMR that we are used to seeing, in organisms that we see in cultures, in typical susceptibility panels. So definitely it was a great episode. It's always great having them, and getting to do an episode with both of them, it was even greater. So I hope you enjoy it and learn a little bit more about biofilms and AMR. And I will definitely post the link to the article in the show notes. So let's go ahead and listen to the episode. So in today's episode, we are talking about microbiology again. It's very exciting. I have two guests. They have been on the podcast before. They're very active in the microbiology community, and we'll also say medical lab sciences. So they're going to talk about an article that was published in the American Society for Microbiology, which is titled "The Role of Bacterial Biofilms in Antimicrobial Resistance." This was published on March 6th of this year. So with me today, I have Dr. Andrea Prinzi. She's an infectious disease medical science liaison, and Dr. Rodney Rohde, which is a professor and chair from Texas State University. Dr. Prinzi and Dr. Rohde, welcome to Let's Talk Micro.
Hi, Louise. Thank you.
Hi, Louise. Thanks. It's always a pleasure joining you. Looking forward to it.
Yes, definitely my pleasure having you. So let's go ahead and just, start with some basics. So what are biofilms?
Yeah, thanks for the start off here. So I'll get started on this. And Really, if you think about microbiology in general, and if you think about bacteria, you've probably seen a biofilm, whether you're a microbiologist or just someone out observing and admiring nature, because biofilms are typically seen on different types of surfaces in nature, including, for example, rocks and streams. You might see that look like slime or some type of layer that you've seen on rocks. That's actually found on our teeth. So bacteria create these kind of sticky layers on your teeth. That's why it's so critical to floss and brush your teeth, obviously, to get rid of those bacterial films. You see them in water pipes. You can see them on plant roots, and really just about any type of surface out there, because one of the things we absolutely know about bacteria is that they're probably one of the most adaptable microbes that we know, and they certainly have the ability to do so. So when you see biofilms in the medical community, it's a little bit bigger problem, because what it does is it really allows that bacterium to really have more of a virulence or the ability to cause disease. We call that a virulence factor. So certain bacteria, and we can get into this a little bit later perhaps, have the ability to create these things. And as they build and they get thicker and stickier, they can be problematic. And so that's generally what a biofilm is. And I know you have some other questions related to them. So I'll kind of stop right there, and then we can kind of get more into maybe the medical impact.
Yeah, definitely sounds good. Yeah, I'll as we continue, we'll build a little more on it. So definitely, thank you for that. Yeah, we have seen biofilms and definitely many places, and I did an episode where about different bacteria and and like in dishwashers and things like that. So the article says that the majority of human infections they are biofilm mediated. Can you talk more about that?
Sure. So again, we kind of talked a little bit about biofilms and kind of what they are, and Dr. Prinzi may get into this as well later. But just a quick comment that kind of their primary structural um, makeup is something that we call an extracellular polysaccharide matrix. That's a big mouthful. That's EPS for short, and it really creates this very sticky kind of matrix substance that they're excreting. So I want the audience to kind of understand that this biofilm is kind of not only something that the bacteria kind of secrete and put on surfaces, but then they live within it. And then they can kind of be transient. They can come and go within that biofilm. And what this can do with respect to the medical community is that some of the actual primary human infections are what we call biofilm mediated. And that means that biofilm infections are often related to different types of medical devices. Many people out there will know what I'm talking about when I discuss knee replacements or even contact lenses. You might see the recent story where Pseudomonas aeruginosa is in eye drops and things like that. So that's a direct inoculation site for a very heavy biofilm producing microbe. Catheters, implants, different types of heart valves, even joints and screws. So there's that side. That's what we would call medical device related. And then you also have tissue related biofilms, and this would be more involved with chronic wounds. You may have heard of these sometimes referred to as staph infections, and staph refers to a particular type of bacteria genus, Staphylococcus. It also is seen in things like endocarditis, so like heart infections, chronic otitis media, ear infections, cystic fibrosis within lungs. And so when that happens in these biofilms, whether it's medical device related or tissue related, it's really impacting our ability as medical professionals to treat and perhaps even remove those types of infections, because it really impacts what we call antimicrobial efficacy. So that's another big word. But what that means is when you're taking an antibiotic or even an antifungal drug, perhaps these biofilms actually can kind of mediate how well your drug's going to work, because it creates this almost barrier, almost a force field, if you will, around the bacteria. And so it's hard to get to the actual bug to kill it. It can also mediate the immune response. And ultimately, it kind of helps contribute to the bigger problem globally known as antimicrobial resistance. So it really uh, gets into the problem of persistent and chronic infections. More impactful, they can often be polymicrobial. So you have multiple types of bacteria kind of almost working together within a biofilm. And so there's just a lot of far-reaching implications in the medical arena, and it's really difficult to deal with these. So it's a very upfront and problematic issue right now that we're facing in healthcare.
Indeed, it is. And so, as far as there are different bacteria that can make up this and can be in this biofilm. So, what organisms can you see in there?
Yeah. So again, I know Dr. Prinzi will jump into this later because she's done some writing and efforts in this world. But most of the research shows that in many different studies that Staphylococcus is a genus, and we can talk about specific species. So Staphylococcus epidermidis, Staphylococcus aureus, and there are others, are quite often involved in these types of infections. We also have the bacteria that you might have heard of with respect to Pseudomonas aeruginosa. That is a very problematic biofilm type of organism. We have E. coli. Let's see, Klebsiella pneumoniae. We have Acinetobacter. And so I'll kind of leave those as the big ones. We also have Candida auris, which has been all over the news in the last few weeks as a really rapidly emerging antifungal drug. Candida is a yeast-like fungi that can cause biofilm issues as well. And so those are the primary agents, but there are others, Luis, that if you went and looked up that type of information, you might see dozens and dozens of organisms that can cause biofilms.
I might jump in there too. Just, Luis, I'm thinking about for the medical laboratory scientists that are listening, I think this is a important thing to think about when you think about how we write our operating procedures in the lab and how we work up certain cultures, right? So one thing I love about microbiology is how complex everything is. So if you think about, the things that grow on our skin normally, and that they may not be causing disease in one situation, they certainly can become a pathogen or act like an opportunistic pathogen in another scenario. When you think about biofilms, that's when this really comes into play, right? So if you think about a patient that's got like a central line in place for they're getting chemotherapy delivered that way or something to their bloodstream, they have this line in place. Coagulase negative staphylococcus on the skin may not be a problem in a patient that comes in without underlying issues, gets their blood drawn, their blood culture grows coag-neg staph. We might say, oh, that's a contaminant, right? But in a patient with a line, because we know that coag-neg staph could potentially get on that line, make a biofilm, make a happy little home, and then, dislodge these organisms that could then cause bacteremia. In that patient, the growth of that organism may be really significant. And so I think that helps us think through when you're looking at these cultures and you're trying to sort out, what was in the gram stain, what's the organism type that's growing, how much of it is in the culture, is it predominant? You're also thinking about the patient population and whether they have something implanted and whether this organism might be acting as an opportunistic pathogen. We saw this a lot in my it was when I was doing my master's program. I did a lot of work with surgical spine infections. And so patients that had their spines fused, where you go in and you put a metal rod in the spine and then fuse it all up to help straighten out the patient's spine. This is where things like Cutibacterium acnes and coag-neg staph, specifically Staphylococcus epidermidis, were causing a ton of problems in these patients because they get in there, they make these biofilms, and then they kind of fester for a long time. Whereas, someone that doesn't have a rod or something in place, if you just, sampled some of their skin or an open wound and you grew coag-neg staph, you might not think much of it. So I think that kind of helps sort out the pathogenicity or the virulence of some of these bugs in different settings. And that's why, kind of like Dr. Rohde said, the biofilm can contribute a lot to disease in these types of patients, especially if they have something in place that could get a biofilm on it.
Yeah, great points. I was even going to point out in our article that we talk about, bacteria that live in a biofilm, they typically exhibit anywhere from 10 to 1,000-fold increase in antibiotic resistance compared to a similar bacteria living in a platonic state. So, for example, one study showed that antibiotic resistance of Staphylococcus epidermidis in biofilms, listen to this, 100% of the isolates were susceptible, right? So it works when it's in a kind of a platonic state to vancomycin. But when you flip that in the biofilm, 75% are completely resistant to the same antibiotic. So, that biofilm is truly a suit of armor. It's Kevlar to the bullets of antibiotics or antifungals. So it becomes really important in those situations like Dr. Prinzi was talking about, whether it's that central line, whether it's a medical device. I have a good friend who's a healthcare associated infection survivor who is still dealing with a heart valve that has probably Pseudomonas on it, and it's seeding infections, and it's going to probably, eventually be something that might end her life. So my own father has MRSA in his ankle from screws and metal that got put in when he was dealing with some surgery. So these types of things, the public actually does need to be familiar with it and understand it at the level, so that if they see, symptomology around their loved ones and they really don't know what's going on, fevers of unknown origin, other types of wounds that might pop up, they really need to understand how biofilms and at least antimicrobial resistance might be part of that equation.
Yes, definitely. Okay, so we let's talk a little bit about AMR, and definitely this is a very long subject. And to the listeners out there, I know we as MLSs, we cover some and we learn a lot on the job. And stay tuned. As far as Let's Talk Micro, eventually we'll start bringing all this information and breaking it down in terms that everyone can understand. So just bear with me. We're gonna talk a little bit. So, can you talk about some common antibiotic resistance mechanisms?
Yeah, I think I will jump in here. Like you said, Luis, we will save the deep dive into the mechanisms for a later date, which I'm really excited about. But what I think is really, really interesting in the context of this particular article, and when we think about biofilms, is that the AMR is not really the same between biofilms and how we think of it, outside of the biofilm context. And what I mean by that is traditionally what we think of when we think of resistance in bacteria are things like genetic point mutations, or these genetic changes that happen over time that help the bacteria, evade drugs in one way or another. Or we think of things like enzymes, beta lactamases, things like that, or efflux pumps. So these, mechanisms that the organisms have that literally can kick drugs back out instead of, allowing them to come inside and cause damage to them. Those are the things we usually think about, but all of this looks quite different inside of a biofilm, which I think is actually really, really interesting. So the AMR that you think of when you think of a biofilm is this combination of like mechanistic type protection, kind of like Dr. Rohde said, kind of this like armor, and then these other really interesting things happening in deeper levels of the biofilm. So I think the best way to think of it is you've got all this stuff that happens at the top first. So the biofilm is really this like we said earlier, this thick, sticky, slimy membrane that's just hard to penetrate in general. So it's a little bit harder for antibiotics to get inside there, get into the organism and cause any damage. But let's say that they do. Let's say an antibiotic does make its way through that first layer. Once it gets inside the biofilm, the atmosphere inside of there is actually pretty tough to antibiotics aren't alive, so I don't want to say stay alive in, but it's really hard for the antibiotic to stay intact. There are, for example, there's a kind of crazy pH changes. There's a lot of byproducts and wastes that are accumulating inside the deeper levels of the biofilm, things that may break an antibiotic down. So if it makes it past that first layer, it may not make it through the second layer because you've got all this, really toxic condition type things happening there. And then furthermore, the organisms that are inside the biofilm are really close together. And so they can actually sort of talk to each other or exchange information, which makes things even more challenging. So there's a really cool phenomenon called quorum sensing that some bugs do. There's actually a really great ASM Bugs and Drugs blog article about that that we did not write. Rodney, I don't know if you were a part of that one or not, but there's a great quorum sensing article that's available if anyone wants to read about that. But it's essentially how these organisms talk to each other. And then they can also exchange basically genetic information that confers some sort of resistance back and forth. And so when they're in this close proximity, they can transmit these like transposable DNA elements or other biofilm promoting factors, things like that. So not only does that maintain the structure and integrity of this biofilm, which is making everything very difficult, but it's also allowing bacteria to exchange potentially, potential resistance mechanisms that then, complicates the problem too. So it's this like multifaceted, multi-layered situation inside the biofilm that ultimately leads to resistance, but doesn't necessarily look the same. There's also these really interesting cells that are called, I think they're called persister cells. So they're these organisms that can kind of go into a spore-like state. It's sort of like they go to sleep inside of the biofilm. And that allows them to, how when we think of bacteria that have spores and they're really hard to kill, it's really hard to get rid of them. It's the same kind of thing. They go into the spore-like state, and then the antibiotics really can't touch them. They're not dividing when they're in this persister cell state, but they're protected from treatment against the antibiotic. And then once they go back to a platonic state or outside of the biofilm, they kind of revert back to their original state. But when they're in this state within the biofilm, they really can't be touched, if you will. So all of these things are happening at the same time. And the impact of one of those over the other isn't totally clear. I think we're not, at least in the literature, it doesn't seem like we're completely sure of how much any one of those contributes to the AMR problem. I think they all kind of work together. Some may impact the treatment or persistence of the resistance more than another, but I'm not sure which of those that is. I think they all kind of work together to make this scary little environment.
Yeah, one of the interesting things that I'll add to that, one of the ways I describe this sometimes to the general public or to my family, for example, when we're talking about my father who deals with this, is that, and I mentioned it in the article a little bit, I like to think of this as kind of like trench warfare. So if you think about World War I, where they had trenches, where they were digging in and people moved around the trenches to get their weaponry closer to the enemy and things like that, and they were also able to avoid attacks. You can kind of think about biofilms in that way. It's just at the surface, like Dr. Prinzi was talking about, and then all the way down to the bottom of those trenches. And throughout that trench, there is this kind of opportunity for these bacteria to kind of hide and pop up when they need to. And these persister cells, it's almost like a spy. You can send them out beyond the trenches, and it's really, really, I always talk about this as kind of a diabolical feature. They're just really nasty at finding ways to get around our kind of therapeutic activity. So that's my kind of take on it when I'm sometimes talking about it. Is it's just really a diabolical way that they can persist literally and be moved from one, not only between the same genus, but they can even transfer resistance genes to other genera of bacteria. We call that, kind of a transferable genetic trait that you can transfer through your pili and other mechanisms. So that's getting into the weeds a little bit, but to say the least of the matter is that they are absolutely diabolical in how they can kind of avoid therapy.
Yes. All right. And definitely, thank you for that. That's a great explanation. And then I was going to ask about the role of biofilms, and Dr. Prinzi definitely addressed that. As I was reading, it says, the diagnosis of biofilm infections, it is challenging for healthcare providers. Can you touch on that a little bit more, please?
Well, I think I would just add that, if you think about, like, when I think about these patients that had their spinal fusions, and then they would come back months later with some concerning symptoms that might suggest they had a surgical site infection or hardware that was infected. The only way they could really go in and clean this out was to open the patient's wound back up, consider removing that rod, which has been fused to their spine, do debridement, remove tissue, do long-term, probably heavy duty therapy to try to clean this all up. And so I think that's the challenge, is trying to be as non-invasive as possible in making a diagnosis with one of these infections, but also trying to determine how effective your therapy will be if you really don't clean up the source of the infection. And so that's what's so challenging about some of these, especially with implanted devices, is consideration of removal of the device is very important for eliminating the infection. But that's a really hard decision to make if, say the person is receiving some sort of important therapy through the line that's infected, or if having a surgery is something that would be high risk for them, or if the surgery itself is something that's very complicated and could cause a lot more damage. These are just tough decisions to make, and may be essential to, officially diagnosing that type of infection and cleaning it out. The treatment itself may also be difficult because it may involve something like debridement or device removal. But I think that would just be my 2 cents. And of course, I want to stay in my lane here. I'm not, the one ever, actually diagnosing these patients, but just from the work I've done previously and from an infection prevention standpoint, the time I spent with infection preventionists at the hospital while I was doing my epidemiology master's was really enlightening for me, in that the work that they do to try to prevent these types of infections before they happen is really, really important. I think that's where a lot of important interventions can probably be made here. And that's where a lot of the efforts do go, just to try to prevent any sort of hospital-acquired infection, particularly surgical site infections. That's a really big goal of a lot of infection prevention programs for reasons like this, right? That the diagnosis may be really hard to make, and that these are really, really hard to treat once the patient gets them.
Yeah, I would jump in here too and just add, I really want to echo what Dr. Prinzi says about infection preventionists, IPs. I've worked with them as well. I actually have some alumni that have become CIC certified. And I also want to throw in here the importance of not only that group of professionals, but the environmental services professionals who clean rooms and clean surfaces. I've worked in that realm as a microbiologist, consulting with those individuals. And I have this saying, I've written it before, not only for ASM, but for other entities, and that is that all surfaces matter all the time to everyone when you're thinking about these types of infections. So the best way to deal with this is to prevent the infection and avoiding these types of biofilm associated infections. So easier said than done, but really those professionals are so important to the overall healthcare of what I would say the environmental health of a hospital or a healthcare setting.
Yes, definitely. And so I know you touch on treatment for biofilms, so basically, like, and this is not what we do in our work, but as far as, so it would be probably just removing the device, and then if it doesn't, sometimes, as you describe, it can be invasive. So maybe some sort of therapy and monitor the patient. Is that about it?
Yeah, I think that at least a lot of the infectious disease clinicians I've worked with over the years, a lot of them would say, it's going to be pretty difficult to clear up one of these infections if you don't remove the source or fully clean out the source, which often involves removing that device or whatever it may be that's infected. But if there's, if it's a situation where they can't do that because the patient, it's either too risky or the patient really does need that existing device or line or whatever, I think that's where you start to see potentially some really broad spectrum, maybe heavy duty therapies. And I think the reason for that may be that, I don't think we mentioned it earlier necessarily, but these biofilms can be polymicrobial a lot of the time. And so they may, clinicians may choose to use therapy that covers a multitude of organisms. And then given all the AMR issues that we talked about earlier, I think this therapy can be pretty intense too. So I think that's why that, as we said, prevention is just like so important and saves a lot of cost and pain and suffering down the road if we can prevent them in the first place.
Yes, and also definitely, yeah, awareness, and you said, like, making sure that as healthcare workers, right? So definitely making sure we have clean surfaces and educating the staff, and I will say, doing things like you're doing. So publishing this type of information that everyone can see, and we can educate ourselves and learn more about these things. Um, is there anything else that you want to add, either of you?
The only thing I would add is kind of tacking on to what you just said, Luis, and that is I think I'm a huge advocate for science communication. I know Dr. Prinzi is. We love this opportunity to discuss these types of infections as well as our love for microbiology history and many other topics. So whether you are in the public listening to Luis's podcast, or you are a practicing MLS or MLT professional, or you're another type of healthcare professional, you can do your part to educate others. And for me, this became really apparent when I had it, as often it was personal, it was my father. And so, that community out there needs to hear, even if you remember nothing else other than, you can be an advocate for your loved ones when they're going into healthcare, to make sure that, it's okay to remind the physician and the healthcare team that, just checking, doc, is everybody observing the proper PPE? Is the surface is clean? My mom's got cancer and she's going in for this type of catheter or this central line, and I really am concerned about these types of infections. So, you can do those sorts of things, and I've done it personally. So I think it's important that everyone is at least aware of this type of problem.
Absolutely. And I just want to give a real quick shout out also to Dr. Robin Patel and her team at Mayo Clinic. Dr. Patel is the director of the Infectious Diseases Research Laboratory over there. And they primarily, I think they do a lot of really wonderful things, but I know that their research really focuses on biofilms. And she has been publishing in this space for a very, very long time. So if this is something you want to learn more about, or you want to follow some really great research that's being done in that space, I highly recommend looking up her papers and her research team. Again, they're wonderful. They have lots of really great insights and could inform you well.
Yeah, great point. And since you mentioned that, I'll just throw one out too. If you're interested in not only that level, kind of the medical side, I have a colleague literally across the street here at Texas State. His name's Dr. Robert McLean. He's a Canadian. He came here years ago. Now he's an honorary Texan. And his entire career for the past 35, 40 years has been in the world of biofilms. And he has had actual research projects on space shuttles. So he looks at the impact of biofilms in space travel and on the space station. Fascinating stuff, kind of looking at that impact of an environment that doesn't have any gravity, and just looking at it from a different angle, but really fascinating papers and other things to check out.
Definitely. And Dr. Prince, you mentioned a paper about quorum sensing. So if you can send me the link, and I'll go ahead and put that one on the show notes. And you mentioned Dr. Patel, and actually, yeah, she was actually the first guest on Let's Talk Micro, along with other shoots. Yeah, I was reading this article, and then I wasn't sure. It's like, I just been doing this for a few months. Not everyone knew about it, and I just reached out, and I was fortunate enough, like both of you, that whenever I reach out, you say yes and come to the podcast and talk about stuff. So definitely, once again, thank you for taking the time to come into Let's Talk Micro.
Our pleasure.
Our pleasure.
Thanks, Louise.
Thanks a bunch.
My pleasure. And that, my dear audience, it's the end of this episode. I hope you enjoyed learning more about biofilms with Dr. Andrea Prinzi and Dr. Rodney Rohde. As always, I enjoy bringing this information to you. So, thank you for listening. Please continue downloading episodes and subscribing to the podcast. I appreciate the support. Please continue bringing that passion to what you do. It's so important. We do such great work. As always, stay motivated, stay safe, and of course, continue talking micro. Until the next time. Bye.